Good evening, everyone, and thank you for joining us. My name is Dori Jaffe, and I'm the CEO of Hadassah Australia. I want to start with a moment, not a headline, but a real moment from inside Hadassah Medical Organization. Recently, during a missile attack, a medical team at Hadassah Hospital, Mount Scopus in Jerusalem, was performing a delicate procedure on a newborn baby, just a few weeks old. They were inserting a feeding tube directly into the baby's stomach, a procedure that couldn't be delayed. And then the sirens sounded. They didn't stop. They moved. The entire team, doctors, nurses, specialists, relocated the procedure underground into a fortified neonatal unit and continued, calmly, precisely, without compromise. And that procedure was completed successfully. The baby is being cared for today because even under fire, the work continues. Since the 7th of October 2023, Israel has been living through ongoing trauma and uncertainty. And now, with the current war with Iran, hospitals are once again operating in full emergency mode, moving patients underground, preparing for mass casualty events, and continuing crucial care under constant threat. And in those moments, I find myself thinking about the legendary founder of Hadassah, Henrietta Salt, who once said, "Dare to dream, and when you dream, dream big." Henrietta wasn't a doctor. She was a visionary, someone who understood that you can make a real difference in society through medicine, healing, and hope. And today, more than a century later, Hadassah continues healing our world together. Just overnight, it was announced that Professor Avi Rivkin from Hadassah will receive the Israel Prize for Lifetime Achievement at the upcoming Yom Ha'atzmaut. This is the country's highest civilian honor. Professor Rivkin is one of the pioneers of trauma medicine in Israel. At Hadassah, he established the country's first trauma unit in 1992. Over decades, he and his teams have treated hundreds of victims of terror and soldiers and trains generations of doctors. What he built didn't stay within Hadassah. It became a model for how a country responds to crisis. And today, those same systems are being rolled on in real time. And that brings us to tonight. This webinar is an opportunity to hear directly from those living this reality, to understand what it means to deliver care under fire, how medical teams function under constant pressure, and how our Australian community is really making a difference. We are honored to be joined by Dr. Ahmad Nama, Head of Emergency Medicine at Hadassah Hospital in Kerem. Ahmed leads one of the busiest and most complex emergency departments in Israel, where every day is about making crucial decisions in moments where seconds matter, and bringing both global expertise and an Australian perspective. Professor George Braitberg, one of Australia's leading emergency medicine specialists from the University of Melbourne and Austin Health, who immediately after October 7th left his family in Australia and came to Hadassah to volunteer alongside trauma teams treating the wounded. Our conversation will be moderated by Dr. Josh Pecker, Hadassah Australia Development Committee member, who will guide this discussion. I encourage you to use the Q&A box to submit your questions. We will leave time at the end to address as many as we can. Over to you, Josh.
Thank you, Dorit, for your wonderful introduction. It is my great privilege to share the screen with George and Ahmed tonight. The time is incredibly valuable, so we'll get straight into it. We are living through truly historic times in Israel. So I ask you both, we often hear the term mass casualty event, and what does that actually look like in an emergency department, and how can you prepare for it?
George, you are muted.
I knew I would do that. I knew it. I might start and then hand over to Ahmed. I've been an emergency physician for 38 years, and I have both an academic as well as a practical interest in emergency medicine, critical care medicine, and disaster medicine. We teach disaster medicine and disaster management all the time. We focus on the two P's, the two R's, prevention, preparedness, response, and recovery. And unfortunately, the nature of climate change has increased the rate or frequency of disasters by about tenfold since the mid-1950s. And we live in these incredibly uncertain geopolitical times, and terror events have happened historically in Israel. They've had a long history of being able to deal with terror incidents. And in fact, a lot of the research and literature has come from Israel. But ideological extremism is now a global issue, and we see it in Australia through firebombing of synagogues, of shuls, and in the UK overnight, firebombing Hadassah ambulances, and of course we had Bondi occur in December. So we are very much in the world of global terror and mass casualty, unfortunately. From my perspective, a mass casualty event is really one where it's less about numbers and more about the cognitive and system overload that happens. You have to move your mindset from business as usual, where you're dealing with what you would normally deal every single day. You have really busy days at work, and you have all your resuscitation rooms full, but it's still part of what you expect when you come to work. But when you have a mass casualty situation, it is something that is outside your ability to manage in the same way that you would normally manage. So you then have to change your whole model of care, and you start to introduce, mass casualty triage. You start to ensure that people that don't need to be in the emergency department go home in the waiting room. You get people admitted to hospital wards that would otherwise spend a few hours waiting for that to happen. So you try and create capacity, and you call in the resources that you need so that you can then manage the situation. My experience probably in Australia is really thunderstorm asthma and Burke Street Mall, where as director of the Royal Melbourne Emergency Department at the time, we found ourselves in a mass casualty incident. But one thing that I think is so different from our experience here, apart from maybe those first responders were in Bondi, is that we're receiving the victims from the scene. We're not trying to render assistance and care while our own team's lives and our own life might be under threat. And I think the example Dorit gave in the operation on the baby is just one example. And I'm sure that when I hand over to Ahmed now, he can talk about that perspective, not only of the physical threat, but also the psychological and ongoing well-being impact of having to deal with a mass casualty situation whilst you're still yourself under fire. So I think for me, going back to the two P's and two R's, clinicians aren't going to prevent hurricanes. We're not the people that are meant to be policing borders, but we do need to prepare, and we need to prepare in the best way we can, which is through simulation and all sorts of other modes, training, making sure that people are fit for the job that they need to do. We need to be able to respond, and we also need to understand that psychological recovery and factoring community resilience is also something that we should be aware of and participate in as well. But I think it's important at this stage to get Ahmed's unique perspective.
Thank you, George. So thank you for this opportunity to speak. Just to let you know, I'm an emergency physician trained for the last 15 years. I have been running the department here soon 4 years, but there is something I would add. I would add that Professor Braitberg, he was one of my mentors, and I spent my fellowship at Australia in Melbourne. So there is some Australian touch in me based on country-wise, city-wise, and also human. So thank you. George is really have a mentor for me. So I just want to give my perspective. So mass casualty, basically, as George mentioned, it's basically about the event where we have the numbers of the severity of patients are overwhelm the availability of medical resources, right? So this is the concept, and this the mass casualty. I think most of hospitals worldwide have been at some time experienced mass casualty event. It could be, a truck, a bus accident with a few, 10, 15, 20. It's not about the numbers, it's about the resources that you have. And there is a mass casualty event or something that big. So we clarify them into small size, medium size, and large size. So it's about the numbers of the patients and the injuries, and it's more about the resources. And again, most of the hospitals, definitely big hospitals, have faced in their lifetime some mass casualty event. It's something, it's written in the books. It's something that we do training, we educate about it. It comes with our exams that we do in our preparations for our residents. And it's not something unique. But from my perspective here at Hadassah, I can say that we usually do, and even Professor Breitberg have been also actively involved in some simulations that we does for mass casualty events, and we have been training all the time for mass casualty event from this type and that type, whether or not it has some biological or chemicals that it could be involved in this event. So there is different types of mass casualty events. But there is one thing that we didn't train in the simulation. We didn't train how to run a mass casualty events and when we are under fire. So this is this is something that, and I still remember it, that probably a few months before October 7, we did have the simulation. We did have the simulation that what if there is a rocket hit somewhere nearby, and how we can work under threat. But we that we never imagined that this thing could become true, actually. And October 7, after a few days after October 7, we had George also visiting the hospital here, volunteering with us and being here at Hadassah with us. And even since October 7 until now, there have been transformations, okay, or changes. It's dynamic. So at the beginning, we had some sirens, but we were a little bit far from really rockets hitting us, okay, coming from Hamas, coming from Gaza. I would say we are a little bit far, and we were not really targeted at Jerusalem as an area here, okay. But still, we had to work with under precautions, etc., etc. And the most important thing that it could be, it have been changed, okay, in the last year, is basically when the war started with Iran, and when we had missiles above our heads here. They were not only rockets, they were ballistic missiles that they did the collateral damage that no one ever could imagine what they could do. So this is a different game changer. This is a place that you can't operate anything, any patient treatment, if you are not in a highly protective area. It's not there is a threat, you should go under a roof or under a place that you should be protected. This is a place that if you don't have an infrastructure for ballistic missiles attacks ready, it's it's a disaster. So this is the shift. So I think now if I look back, it's basically looking back that, okay, now we give treatment for our patient under threat of ballistic attacks. These ballistic missiles, if they hit somewhere around us, they could affect us, that they could damage us. So we have, even as a leadership, we need to change our thinking of how to win, and how to we keep both the safety for our patients. This is the first thing, the safety of our employees, and the safety for the ongoing. We need to also, you have to also to keep in mind that mass casualty, it's an incident, but we have been like a chronic mass casualty event. We have been in the last 2 years, we have been seeing all the time, every now and then we have some dynamic big siren. It have a cognitive impact on everyone in the country, in the staff in the hospital, in the emergency department. And you should never forget that we still a big department that sees in a daily average 300 patients a day. So these patients, as a tertiary medical center, we need to give them treatment as well. So okay, maybe they will come less, but still we need to be available to give treatment for public, to treat more than 200, 250 patients a day, to treat our mass casualty. Meanwhile, we need places to admit them. And meanwhile, we need to take care of everything to be in protected area. And one more thing, which is important as well, don't forget that each one of us as employees, doesn't matter which ruler you are, in a leadership, in a doctor, nurses, paranurses, we all have families that they are also under threats. Okay, so we also this is also in big events like this, when we operate in a crisis, we have to, as a hospital management, we need to make sure that, okay, what we will do with, so there is no kindergartens, there is no schools, there is patient people at home, we need to be at hospital, we need to be at home. So it has it's a big umbrella which affects us in cognitive. So I think most probably many places, if they ever had such an event, it was a point periodically, but we have been living like this for the last probably 2 years now, or who counts, maybe more. So it's we stopped really counting. So it's every time it's dynamic, it's different. The mass casualty is the small part of this big package.
Thank you, Ahmed. And George, to you now, reflecting back on October 7, initially you were planned to visit Israel for a conference, and despite the events, you ended up traveling to Jerusalem anyway and began working and helping out at Hadassah in Jerusalem. Tell us about a key moment that has stuck with you in these following years.
Thanks, Josh. I mean, ironically, one of the things I was going to do when I went to Israel was observe a large multi organization mass casualty simulation that was being put on. It was also a multi-cultural jurisdiction as well. There were observers from Canada, Belgium, and this was all being put on for over a 3-day event with the military, the IDF being involved, as well as civilians. So that was what I was coming to observe. And then, of course, October 7th came, and I was also going to do some work in Hadassah, doing some lectures, which I do every year. But that was the main reason I was coming. And then October 7th came. And so I was really fortunate. I had tickets. And at that point and throughout the time, really, there was only a small window where Emirates wasn't flying into Israel. So, I was able to keep my original tickets through the CEO of Hadassah and Ahmed. We got me a medical license in about 10 days. It was quite extraordinary because it meant that I could actually come and do something, and that was very important to me. I didn't want to come as an observer. I actually wanted to be useful. So being able to then work with Ahmed and work inside the emergency room. The trauma base was very important. I think those memories that I have started with stepping off the plane in Ben Gurion, and you walk. There was no one else at immigration. It was completely empty. There was one immigration officer that sort of looked at my documentation and waved me through. You get into the baggage carousel area of the airport. It was completely empty, and none of the carousels were moving. I only had cabin luggage, so I just went straight through. There was someone from the hospital picking me up. The roads were completely empty. For those of us that lived through COVID here in Melbourne, it was like the deepest part of COVID. There was no one on the roads. There was no activity in houses. I think people were still feeling under threat, both physical and psychological threat from what had happened. There hadn't been, I guess, an opportunity to think that there wasn't going to be another attack. And so that was really weird. It was, like those science fiction movies where there's almost that end of world feeling. And then you get to the hospital and, everyone is there working, despite the fact, as Ahmed said, they've all got families, they've all got people that they care about. They all came to work. They looked after an Arab Israeli, a Jewish Israeli, an Orthodox Jew, a Bedouin, man, woman, child, it doesn't matter. It was actually relatively quiet the first week I was there because people were deferring their care. They didn't want to leave their houses. It was before the ground invasion into Gaza had started. And it wasn't until the second week when we started to receive IDF soldiers that things changed dramatically. And I think that's probably one of the impressions I had, that, the trauma room with the first casualties arriving, every clinician in the hospital wanting to be not even wanting to be, but feeling the need to be part of that management. That the soldiers were precious commodities, and we needed to help them. And the way the psychosocial welfare the soldiers looked after, making sure that they had access to a phone so they could tell their parents that they were okay or alive, and all that went in simultaneously with the management of the actual physical injuries and the trauma. It was just such a well-oiled machine. I mean, I think Ahmed will say probably there were too many people in the trauma room, and part of what he had to do was throw people out because the gynecologists that wanted to help, or the oncologists that, but I think everyone felt the need to be in the room and to be able to do something for the soldiers. So they're sort of my early impressions, was that the fact that it was so eerie when I first arrived, that despite this feeling of vulnerability that everyone had in Israel, people still came to work, still treated others. And then that outpouring of emotion when the first soldiers came through, and I thought that was just incredible.
Thank you, George. And Ahmed, to you now. Being at Hadassah full time and in an ongoing and extended capacity, I guess Israel generally is known as the startup nation and has some unbelievable innovations through the most trying times. What are some developments from events like the October 7 and unfolding conflict with Iran that continue to be implemented in quieter times and times of peace?
So, from a country point of view, I think it would be difficult to list all of them, but I can tell you definitely, just that only in the last 2 weeks, even at the middle of the missile that we have been the threats under the sirens at Hadassah now, we built up. Actually, we brought a team from abroad, and we have now a new machine for nuclear treatment for for oncology patients that have been now installed at just a week ago at Hadassah, even during these timings. So it was important for us still to bring such things. From innovation point of view, I can tell you that I know that here at the hospital we are working now on a few projects regarding one of the expertise that now I think the whole country gained in Israel, especially the hospitals, the healthcare system, is vertical admissions of patients. It means that you can imagine that every hospital, big hospitals like Hadassah and anywhere else, our everyday capacity to have, if we have 1,300 beds, we are usually fully occupied, like any big hospital worldwide. And imagine that within 24 hours, we need to push down our numbers to 45-50%, these patients that need to stay here. So one of the innovations that have been now occupying many of us is build up systems to vertical admissions, evacuations. It's all about patient safety inside this big crisis. And it's also managing mass casualty. Also there is many innovations in these things because patients documentation, follow up, their numbers. This is something that we have innovations involved as well. So there is many projects here, and I know from my colleagues in Israel that have been pushing into these fields.
I mean, one of the issues that Israel has overcome years ago was having a unified identification number, and they also use the ADAM system where they take photos of victims as well, so that they can later identify them if they can't identify them immediately, which of course is really important because victim identification is so essential. And I think one of the lessons that we need to learn in Australia is that we need to understand that in a mass casualty situation, our concerns about privacy and confidentiality need to be tempered with the fact that we need to be able to identify patients so that we can then reassure family members, reach out to the important people. But unfortunately, we're still trying to struggle with that. But in Israel, it's their system is just superb.
Thank you, George. And Ahmed, back to you. Not only as an emergency specialist, but as a director, where you're charged with making incredibly difficult decisions about resource allocation. How do you prioritize staffing issues and how to allocate resources most efficiently in these most trying times?
So one of the things that we learned actually in during the last 2 years, but now especially when there is again another big attack and war again with Iran, is one of my roles is to make sure that the staff is okay. And staff is okay, it means we need to give them access for first they have to know that they are safe. So it's a lot about being on the ground, speaking to the every worker, every employee. We have to be here physically, to just not to tell them what to do. You have to be here to with the staff, and the most important, to give them access if they need any help. It could be psychological, it could be speak to someone, it could be ask them how are you, what you need. It could be, as I told you, as I mentioned already, it could be sometimes they want to come to work, but they have kids at home and they can't leave them. So as a hospital, we managed through the municipality of Jerusalem to open immediately within 2-3 days kindergarten or until age 12 or 13. So for employees that they must work. We give them the access to have a few hours their kids in a place that it gives them also some time to be at home, to be with themselves, which is also important. And it's also very important to make sure from staffing point of view that if there is nothing happening now at the hospital and they could be home, we send them home. Because when there is a critical issue, there is mass casualty and there is overcrowd and there is incident that they need to come, as George said, they will come. You can't stop them from not coming here. So this is also some dynamic game that we have to be aware of. And one more thing which is important that I have personally learned from these big things that we have been experiencing, it's not about making clear black and white rules when to do what to do. Okay, these situations need every morning. There is it's like making up a committee of the department, which is doctors, nurses, others from the leadership committee. Okay, and we have every day. We meet. It could be Zoom meeting, but usually we meet in the morning. This is usually start from the hospital directors, but also in the department here. We go through critical things. We go over things. We go over staff, equipment, things to do, and very important also dynamic, because many things are dynamic as well. So if the hospital beds are available, then I can admit patients. If not, then I can't admit them. Maybe I can. Now we have adopted a new system here at Hadassah that we have many beds. So we opened another extra underground protected area. It took us maybe, I think, 2 weeks to open that from the beginning, or 10 or 1 week. But meanwhile, we have a big protected area at Mount Scopus. This is the same institute. So we send patients, transfer patients there. So we need to build up. You can imagine it's like building up a system, a committee, how to transfer safety patients from this ED from hospital to Mount Scopus and to the other area, which is in this campus, but it still need. So believe it or not, we bought a car with a driver, with the ambulance, and the ED is in charge of it to transfer patients. It's all on top of the things that we do, because we see that we send patients. So you cannot manage these things just based on say this is how we should do. It's about meeting every day, at least once, with the key players and making dynamic check your resources, your dynamics, what is the availability, what is the equipment. Sometimes, luckily I would say we know we have a good experience now that we know that we don't have equipments shortage, and if yes, we know how to manage quickly to bring equipments from hospital, from departments, but it's also something that it's in our checklist. It's the art of dynamic speaking, availability, being on the ground, and to look at the big picture, to check your resources, check your employees, and being open for. And one more thing that we adopted personally, I did it now in this period, in the last since the beginning, day one of the war or day two of the war until now, every single day we send like a newsletter or a paper, 1 page for the whole ED of what's happening. So we have to be clear with them. What is things that we need to write. So for me as a director or the head nurse, or whoever have something important to say, patient transfer, employees, accessibilities, what is the rules now for the home front command changes, if anything change, we put it in a 1 pager and we send it as a newsletter every day. So all the information is basically there.
Excellent. Thank you, Ahmad. And passing on a question that we had submitted by one of our attendees. Perhaps we'll start with George, and we'll try to keep it brief as we're coming towards the end of our webinar. From a human perspective, what have you observed both across here in Australia and in Israel? What enables these doctors to continue working through the challenges? Is it a sense of purpose? Is it sheer grit and determination? Tell us a bit about the human side of what continues to enable these professionals to work.
Thanks for the question. I guess in the process of running the graduate diploma in disaster and terror medicine at the University of Melbourne, I've had the opportunity of actually interviewing lots of people that have responded. We interviewed the first paramedic that went into the Christchurch mosque. I had the opportunity to interview Mendy from Hadassah about Bondi. I've interviewed some CEOs about leadership in crisis, whether it's COVID or other events. And I think one of the things from those interviews that I gained is that I think essentially healthcare workers do what they do for altruistic reasons. But when there is a common goal, and that common goal is much more easily articulated if there's an external threat, then that altruism becomes an individual's mission, and there's this coming together, which is what I described in the trauma room, which is what Ahmed described. And I think one of the things is that you really want to have the people that you need there, who have the skills and the ability to help. You want to have roles for other people that don't necessarily need to be in the trauma room. So whether, and Ahmed described an emergency operations center where you've got people doing logistics, people doing workforce, people doing finance and other roles, such as working out how to get patients from one hospital to another hospital. And importantly, collecting data, because we need to know where people are and we know what's happening with what we're doing. So everyone who's got a role, there's never, I don't think there's there's never an example where you'll never get enough people. It's really about making sure that the people have the skills you need, you bring together, that you don't dismiss those that want to help but may not have, you don't need them at that particular point in time. So it's very important not to marginalize anyone, because the emotions and passions are very high. So I guess the important thing really is it's not will we have enough people? It's making sure that you use people appropriately, that you value everyone's contribution, and that if you don't need them to do something at that particular point in time, the way you redirect them to help in another way is really important, so they don't feel that they've been left out. And that's often harder. I remember when we had the Burke Street Mall incident at the Royal Melbourne, the head of internal medicine came down, and the first thing he said to me is, I don't know anything about surgery or trauma. What can I do? And my response was, well, there are people in the emergency department that we haven't seen. They've got medical conditions. Take them away so we don't have to have them in our department. We can make capacity for the people that are coming through, and then go upstairs and start discharging people, because then we need to have capacity for when the people leave the emergency department. So just being able to amplify people's passion and altruism, I think, is an important step.
And thank you very much, George. George, Ahmed, is there anything else you wanted to add briefly about the sort of human side and working through the crisis? I know you've touched on it already.
I'm not sure I have something extra to add on George. The only thing I would say that the Israeli healthcare system is resilience. It's something that I think many other sectors should learn from. It's something that we should be proud about, and it's something that functions regardless or on top of everything happens. It's amazing to see all the emergency departments and hospitals, how they work side by side, regardless of ethnic genicity, gender, beliefs. And it's all about really resilience and a matter of treating and being here for patients and for injuries. It's not something, I'm not sure I can explain why, but it's all about, this is facts. And every time in crisis, you can see it even more and more obvious and bold. And this is what have been happening now in all emergency departments, all healthcare system here. It's a sector where I am praying sometimes that this should be kept as is, because it's a model of how systems should work.
Well, thank you, Ahmed, and thank you, George, so much for both of your incredible insights into the life of
Thank you.
emergency medicine. I know that's all the time that we have for tonight, but if you ever wanted to start a podcast, I would be fully supportive of that. I'll now hand back over to Dorit for the closing remarks.
Thank you. Thank you, Ahmed. Thank you, George, for your insight, for your honesty, and for your extraordinary work that you are doing every day under such complex and challenging conditions. And thank you, Josh, for guiding this conversation so thoughtfully. I would also like to acknowledge and thank Hadassah International for helping make this webinar possible. What we've heard tonight is not theoretical, it's real, it's happening now. And it also comes with immense and ongoing need. And that's why at Hadassah Australia, we have launched our campaign, Critical Care for Critical Moments. As missiles comes to target Israel, Hadassah Medical Organization is at the forefront of saving lives. A decision made decades ago to build underground operation rooms is making Hadassah one of the few hospitals in Israel able to perform uninterrupted surgeries under fire, treating mass casualties and war injuries in protected spaces. And at the same time, Hadassah is the leading hospital in Jerusalem in treating severe anxiety and trauma as the country grapples with unimaginable stress. Left untreated, deep psychological trauma can result in devastating consequences. Children and adolescents are especially vulnerable. We are, quite simply, in a race against time. You can learn more about our campaign and how to support by visiting our website, hadassahaustralia.org. Every contribution of any size will make a real and immediate difference. Thank you again for being with us tonight. Let's hope for peace and quiet days. Wishing you all Chag Pesach Sameach. Good evening. Toda Rabba.